Awuno Williams once said, when a woman dies, a family dies, because it is how much role she plays in that family. I am Jessica Ahedor. The mantra to end maternal mortality in Ghana could be addressing the 3 delays, but a strong leadership is required to have a healthy woman. Maternal mortality accounts for 14% of all female deaths, making it the second leading cause of female mortalities in Ghana.
Maternal mortality is the death of a woman while she's pregnant or within 42 days after termination of the pregnancy, meaning either pregnancy terminated before it matures or she has delivered. That's what you mean by the 42 days.
Currently, Ghana's maternal mortality ratio is at 380 per 100,000 live births. Data from the Ghana's 2017 Maternal Health Survey suggested that about 75% of maternal deaths are linked to direct obstetric factors such as postpartum, hemorrhage, sepsis, preeclampsia and eclampsia, birth complications, and unsafe termination of pregnancy, among others.
We are what we call the 3 delays. It's like a strategy that we use to be able to reduce or prevent maternal mortality. And what that means is that usually for some pregnant women, the first delay is that they even don't know what they are going through is a complication or an emergency. They don't even go to the hospital. So they delay in seeking help. Then there's a second delay. That is what it means that they decide that they want to go to the hospital, but they don't get to the hospital on time. That's the second delay. Then the third delay is that they get to the hospital all right, but because of challenges with the facilities, either the health personnel, either equipment and all that, they are not able to get the right treatment and they die.
While many of these direct causes of maternal deaths are preventable, the literature on maternal health in Ghana have often highlighted how women suffer either one of the extreme risk of obstetric complications and the death due to what is termed as the 3 delays: deciding to seek care, reaching the healthcare facility, and receiving care. In rural Ghana, most women are victims of all the 3 delays in most cases: poorly resourced healthcare facilities, limited personnel, poor road networks, lack of funds for transporting emergencies to better resourced hospitals, and low level of decision-making power. Mercy Apia, a 32-year-old at Krobomensia, who survived yet another incident which nearly claimed her life. At about 12 a.m., my water broke. My husband went to his cottage where he farms, and I had to call my younger sister to call a cab driver who lives 20 miles away from my residence. We didn't get the cab, and I have to use a boboya, the tricycle. Even in my pain, I had to alight from the car and walk after we got stuck, and the car could not climb the hills because the roads are not motorable after it rains. The physician specialist said I developed complication due to the nature of the road and the delay in reporting to the facility. He says, I can't go through normal vaginal delivery, but a cesarean section. At the time, the baby's head was almost coming out because the part of my pelvic that holds the baby got ripped off. In a research published by Dr. Kwesi Frimpong and his team on emerging issues in public health, a perspective on Ghana's healthcare expenditure, policies and outcomes in 2017, stated financial malfeasance, lack of commitment towards the country's health sector as major hurdles. The paper revealed how Ghana could not honor the Abuja Declaration pledge of allocating 15% of GDP to healthcare, among other promises. Although the Ministry of Health has reported increment for the health sector in the last few years, but these increments are inadequate and has not made any significant impact, especially in rural Ghana.
There are also cultural barriers, socio-cultural barriers that serve as obstacles to many of the women to get access to maternal health, because some of them don't want to visit the cheap compounds or the nearby health facility because they don't want their body to be exposed to the doctor or to have a look at their body. It's a matter of explaining the issues of the day to them so that they will not only take the traditional way of healing and assessing health, but also inculcate the current modern medicinal method so that it can enhance their health.
Dr. Kwesi Frimpong maintained though Ghana's health sector has seen some level of improvement, but for the inequalities that exist, rural Ghana is yet to see that change.
Health is priority of life, and in order for us to achieve our SDG goals, especially goal 3, it talks about promoting healthy lives and well-being, and failure to achieve any of the goals, any of the 17 goals, means we have failed.
Health economist Dr. Gordon Abeka Nkrumah believes if women are educated properly on their right to make informed decisions about access to care, maternal mortality will improve significantly in addressing the socio-cultural barrier, among other challenges. Many literature reviews have cited poor road networks in rural Ghana, inadequate human resources, lack of requisite tools and medications in health facilities as a major threat to primary health care in rural Ghana.
If there is consistent antenatal care and things are monitored, they know when delivery is due and some sort of planning would have been done. And investment along that service chain, I guess is pretty much important. And here, yes, investment in people, not necessarily brick and mortar. Yes, investment in equipment, in already existing facilities, I believe would be key. But like I've said, social investment in women's education is key.
Before 2000, it was estimated that between 540 and 650 mothers die for every 100,000 live births in Ghana. With this high mortality rate, the Ghana Health Service implemented a number of policies to reduce maternal deaths. The introduction of antenatal care policy and a safe motherhood initiative in 1998, followed by the delivery exemption policy in 2003 to provide free maternal delivery to reduce the financial constraints associated with access to care through the National Health Insurance Scheme.
One of the strongest barriers to service or to access is cost. So women are not able to access the services because they don't have the money. I mean, you hear stories about people who have been detained in hospitals because they come to deliver, and then because they do not have the money to pay. Also, a huge deterrent to women to come to deliver. They say, we are coming to the facility, bring a bottle of Dettol, bring a napkin, bring a rag, bring tissue, bring this, bring soap, bring this. And these are costs that are not part of what is called. So the women count all this and say, look, if I deliver at home, I don't need this. Okay, and they are collecting that from every single woman. Aside that, if you don't have it, they have it in the water they are selling to you. You have to pay for it. I mean, they deter people from coming to the facility. Okay, so you can also remove the cost in terms of NHI, I mean, because of free maternal health care. But you can't leave that alone and see that it's going to work. Okay, policies and strategies like that will have to be fashioned in a way that you monitor and make sure that the ingredients that will make it work are available. Otherwise, you will have a challenge.
Ghana seems to have performed well in reducing maternal mortality as compared to other countries in the sub-region like Mali, Guinea-Bissau, Guinea-Conakry, Burkina Faso, Niger, Nigeria, and Togo. But when using Ghana's maternal mortality rate against her peers like Singapore, Malaysia, and China, experts say Ghana has a long way to go. It is therefore critical for Ghana to improve on quality of life of expectant mothers after cesarean section and make maternal experiences after childbirth a priority, while at the same time strengthening and scaling up health impact interventions that will increase deliverability in health facilities in rural Ghana.